Thanks for that kind introduction, and I'm so honored to be here to honor Sheila today. Uh, this is work that's very close to my heart. I know a lot of people I come across will say these are, some of the residents everywhere I've worked is like, these are soft topics. And hopefully by the end of today, we'll understand that this actually has hard outcomes. It makes a difference to how our patients do and how well our colleagues thrive. So we'll talk about the ubiquity of bias, prejudice, and racism in healthcare. We'll talk a little bit about the underlying neuropsychology, and then some practical strategies of what we can do to address these, while understanding that there are challenges to addressing something that is so ubiquitous. A few disclosures about myself. I feel like it helps to explain to you that coming from the perspective of an immigrant from Jamaica, I went to medical school in Jamaica. I had very little contact with the, with the U.S. before that, apart from television. And so a lot of what I'm telling you now is just what I have learned after living here in the U.S. for over 20 years. You should know that my father's Chinese, my mother is Black. And so that makes a big difference in terms of how I see the world, and having that mixed perspective. This was my grandmother, Vera. That's my only picture of her. But the Lees, my grandfather came from China. The Lees love to take lots of pictures. And I wanted to show you this picture of me at around 6 years old, because I feel like that is the first time I found out about race. Because before that, I was skipping around happily. And I don't remember how it came up, but my mom said, Allison, you know you're Black. And I said, what are you talking about? She doesn't know her colors. And I told her, I'm brown, you're dark brown, daddy's beige, my shoes are Black. And she couldn't convince me, and I didn't know what she was talking about. And I just remember that conversation because there was something heavy about it. And it was like, when I think back, it's so sad to have to explain to your child that what I'm trying to tell you is that as you walk through the world, people are going to make assumptions about your level of intelligence, whether or not you're a physical threat to them, simply because of the color of your skin. And I also want to share that I'm married to a Jewish man. And so that also gives us some very interesting experiences as we move together throughout the world. So I want to name this as a brave space because I feel like sometimes there's discomfort in talking about race and privilege. And I wanted you to know that I'm going to be completely transparent and honest. And I come at this from a positive space. So bias is a tendency to favor one person or one thing over the other, generally unfairly. In the 90s, Greenwald and Banaji came up with this term, which I think everyone's heard about now, implicit or unconscious bias. And this idea is that we tend to think about bias as something that we actively think about and feel, whereas they were trying to explain to us that a lot of this stuff happens under the surface, below our conscious knowledge, and then it ultimately can lead to discriminatory behaviors. So the components of bias are described as being cognitive, and those are the stereotypes that we hold, affective, which is prejudice, and then there's the behavioral aspect of bias, which is discrimination. So prejudice is defined as an unreasonable dislike or preference for a person, group, custom, et cetera, based on their race, religion, sex, and so on. And so prejudice is more about that feeling that you have. It's that affective component. And I have a unreasonable dislike for anchovies, according to my husband, but I just don't like them. And there's no, I don't feel like there's a moral, anything moral attached to it. I just don't like it. And I think it's really important to be aware of prejudices you may have and be aware that they may be completely unreasonable. I may feel uncomfortable with people with very heavy accents or certain strong smells of food, and that could affect my emotional response to a patient. And if I'm not aware of that, the patient will feel it. They feel that lack of warmth. They feel that aversion that you have internally. And so for me, what I'm trying to get across is if you're aware of that prejudice, you say, I don't know why, but I just don't like this. You walk into that room being aware of that, and it helps you to have a better connection by saying, I'm going to spend more time, I'm going to make more eye contact, even though naturally I would have an aversion to this group of people. So I think around the time of the COVID pandemic, the disparities in outcomes really made it clear that there's differential care and differential outcomes according to race and ethnicity. And then, of course, in the wake of George Floyd's death, there was a heightened level of awareness about this. And in terms of the outcomes that we see, there's so many studies which I'll just zip through. Michael Andre and his colleagues showed that there's an association between socioeconomic status and utilization of antiemetic medication. And they're making this point that a lot of us think of our PONV prophylaxis as something automatic. But how is it possible that we're just less compulsive when we recognize unconsciously that this patient is a low socioeconomic status? Some of members of that group came out later in anesthesiology, also showing that using the MPOG data, that Black versus white race was associated with less antiemetic administration. And compared to white children, this is at the University of Michigan, they showed that if you're a Black child, you're less likely to have a parent coming to you in the operating room, and you're less likely to have pre-op midazolam. And the thought process is that people somehow, there's an adultification of Black children. Black boys are seen as bigger and stronger and more threatening. And so this is something to be on the lookout for. You all know Alex Butwick and folks here showed that Black women were twice as likely to have general anesthesia for cesarean delivery. We know that Black women are more likely to experience severe maternal morbidity, no analgesia for delivery. And it's even after adjusting for things like primary outcome and medial outcome and, primary insurance and median household outcome. At Columbia, we looked at New York State data and at epidural blood patch rates and found that there were different rates according to race, with white women having a higher blood patch rate, 53%, versus Black women, 35%. And the timing of the blood patch was delayed if you were Black or Hispanic. And this has downstream consequences in terms of costs. At UCSF, your neighbors, they found that low English proficiency was associated with greater length of stay and higher cost of hospitalization. And we see that in the pediatric data as well. So the elephant in the room is that our providers may have bias towards patients. We may be discriminating based on race. And I think part of the problem is that there's this moral component. We think I'm a bad person if I have bias. I'm a bad person if I discriminate. And I want to sort of normalize this, because I usually ask people to put up their hands, do you think you're a racist? And I raise my hand, because it's impossible to live in our society and not absorb some of these stereotypes, which we'll talk about. Men in the US are over 6 feet tall, only 40.5%, but more CEOs so we tend to attribute height to intelligence and likability and power. There's lookism bias. We tend to look at good-looking people and think there's a halo effect. You're going to tend to see them more favorably and judge them to be smarter and personable. It's even being talked about in Forbes magazine. Time to expose the attractive bias at work. There are something like 140 cognitive biases that have been described, and it's pretty amazing. And when you start to name them and describe them, you'll start to see day to day that this is something that we experience and probably carry out every day. There's anchoring bias. You get called anesthesia stat to the OR. The ENT cases turn. People are pulling up epi because giving albuterol hasn't changed anything. And you might walk into the room and be like, the tube is kinked. And there's so many biases at play. You're anchored on one thing. There's also bandwagon effect. If everybody else walks in the room and thinks that this is the diagnosis, then you're sort of going to jump onto that. There's confirmation bias, where you convince that there's something wrong with the device, but the patient is actually truly hypotensive and you're trying all kinds of things. There's affect heuristic, where you're swayed by emotional reactions. There's outcomes bias, believing that clinical results are attributable to your prior decisions, even though there's no reason to think that. So on a social level, we rapidly categorize situations. And it's usually race, sex, age when you see a person. And studies show that you make that determination in 1/10 of a second. It's that automatic. And I was trying to find a representative video, and I realized that when I looked at this video, I immediately knew what I assumed this person's race was, what I thought their sex was, and whether I thought this was an older person or a younger person, almost immediately. And we don't have time to go through, all the different types of studies, but this is one example of a study using event-related brain potentials, asking people to think about whether a person's male or female, Black or white, and attention was preferentially directed to Black targets very early, especially by the white people in the study, and gender a little bit later. Now, we know, all of us, that from the time we were babies, we're starting to recognize faces. Babies are starting to pay attention to their parents' faces and voices. And in the 90s, they discovered there's a fusiform face area, which is very highly sensitive to facial features. And this was a study in China where they had adults looking at other out-group faces, which were mostly white people. And it was noticed that they categorized very rapidly other race faces more accurately. And this is using functional MRI technology. And they also found that more cortical resources became engaged during the categorization of their own race. So we tend to pay more attention to people who look like us, as opposed to, we rapidly categorize someone as not mean, an other, and we pay more attention to people who look like us. Similarly, this was a study looking at attention to eyes and differentiating true and false smiles. And they used eye tracking data. I won't go into the details of the methodology, but they found that white participants better distinguished false smiles for white persons versus Black persons. They did not find the same for Black participants. And it seems like attention to the eyes in the photograph predicted how well they were able to rate this. So, when you think of, I'm sure many of you heard, and I, apologies if, for making these kinds of statements, but I've always grown up with people saying things like all Asians look alike. And I think many of you have heard that before. And I think this is unfortunately part of the fact that there's a less attention to discriminating facial features for people who don't look like us and who have been othered. So there's a biological basis for all of this. There's a reason that we evolved to make rapid decisions, categorize threats, and a lot of this has been found to be occurring at the level of the amygdala. This is threat perception, the insula, this emotional, your visceral response, your level of empathy towards a group, and the striatum and orbital and ventromedial frontal cortices. We're hardwired to take these shortcuts in our brains. And it's just how we make sense of the world. If somebody says, I got a dog, you say, okay, I'm in my head, I'm 4 legs and a body and a head and a tail. Okay, what kind of dog did you get? And then you start to categorize in your mind, because as soon as you say the word dog, you sort of have that idea of what we're talking about. We categorize people according to different factors of similarity, whether it's ability or disability, obesity or not. Some stereotypes are readily accessible to us, and they can actually impact the way we behave. I was very interested in a study looking at math students in college, math college students who were Asian women, and they randomized them to think about what their gender was before they did a test or their race, and there's a stereotype where Asians are good at math, and the ones who were thought about their race performed better than the ones who were asked to think about their gender, because we think of women as not as competent in the STEM fields. Outgroups seem to be more threatening when the in-group is large, which what comes to mind for me is the way that transgender people are only about 1% of the population, and yet this has, triggered widespread laws across the country against a very, very tiny, tiny group. When interpersonal relations with the members of the out group are infrequent, we tend to other them, and it's much easier cognitively to consider a group as a whole and ignore the qualities that distinguish individuals. So where do stereotypes come from? How do we form these stereotypes? How do we end up sharing these stereotypes socially? Some of it has to do with your level of exposure. We absorb information through social media, entertainment, news stories. If you watch the news, you'll see that although Black folks commit crimes at the same levels as white folks, they tend to report crime committed by people of color more frequently on the news. You're now thinking that all undocumented immigrants probably cause crime. You tend to view members of an outgroup more similarly to others of an in-group. And there's something called fundamental attribution error, which I find interesting. So if someone's late and they're a member of an outgroup, you tend to think that this lateness is due to some kind of internal difference between that person, versus if someone's in your in-group, you'll be like, oh, maybe there's a lot of traffic. And so we also tend to somehow pick up on the people who are the most extreme in terms of their behaviors and attribute that to the entire group. And I share a story that, I'm from Jamaica. I had not met many Americans, especially people from the South. And my perception of people from the South was the Beverly Hillbillies. And I come as an intern and I go onto the floor and we're doing rounds, and the chief resident opens her mouth and she has this thick Southern drawl. And I was like, oh my God, are we okay? Because in my mind, I was thinking Ella Mae Clampett, and I had this idea that people with Southern drawls are not so bright. And that was my stereotype, because I had no contact with anything else outside of Beverly Hillbillies and cowboy westerns. And she actually started to talk, and I was like, this woman's brilliant, but that was sort of counter stereotypical programming for me. And it's sort of just an example of why diversity is so important, because if you do not have contact with people who are not like you, you will tend to stick to these kinds of stereotypes. Socialization is important. I don't know if you've seen this ad before. Can you hear?
Show me what it looks like to fight like a girl. Now throw like a girl. So do you think you just insulted your sister? No. Yeah, insulted girls, not sisters. Dakota, and I'm 10 years old. Show me what it looks like to run like a girl. Throw like a girl. Into you when I say run like a girl. Means run so you can.
And I've always found that ad very moving, because think about what we tell girls all the time, and the fact that we can't see women as leaders, elections aside. So one thing to remember is that when you are tired, you're handling multiple emergencies, even though you strictly believe that you have egalitarian beliefs, unconsciously, you're going to be suddenly, you have someone coming to the OR, you're running down the hallway, you're going to be like, oh, okay, what do I know about Muslim people? What do I know about people who look like this or this size? And you start making these judgments of that person. And some of this is all based in cognitive load theory. If you're overloaded from different directions, you're going to sort of take these shortcuts. And then instead of doing the slow thinking where you're absorbing the situation and trying to make a good judgment, you're jumping to fast thinking, the dual process theory. And many of you have heard about the study where they looked at medical students and lay people as well, and found that there were all these false beliefs about Black people and white people. And some of this could also play into some of the literature where we see that minority patients tend to get less well covered pain control. There's some, myths and beliefs that Black people's nerve endings are less sensitive than white people. Their blood coagulates more quickly. They're more fertile for some reason. And Michelle Van Ryn has done some really interesting work, and she emphasizes to us that we always think that we're going to be completely fair. We walk into a room, we see a patient, we're going to make judgments based on their lab results and our physical examination, our history. But we're always mentally assigning people to classes and groups, and it's completely automatic. And she, advises us that this strategy is common to all humans and all cultures across the planet. And the expectation that as physicians, somehow we're completely immune and not affected is unrealistic. And she has come up with a, flow diagram of how these different encounters, factors will influence disparities in treatment. And it's a lot, but I just wanted to share some of the studies that have been done where they found that cardiac patients, race and ethnicity, negatively influenced physicians' ratings afterwards of their education, their intelligence, their personality. There's another study showing that white providers who scored higher on the implicit bias testing, but not explicit bias, when you look at, you observe these interactions with patients, they speak faster, they dominate the conversation, they're not allowing patients to respond. They're using more I, first person plural pronouns. And so this is a kind of work that's done to show how differently we treat patients. There are other studies showing they viewed videotapes, and the level of assertiveness of the patients seemed to improve the positive, improve their recommendations for the treatment plan, which is interesting, which when I do some of my patient focused podcast type things, I'll say like, educate yourself, make sure you walk into the situation with informed as much as possible, because I feel like you're better able to advocate for yourself. And patients' perspectives, when you look at all, survey studies, they consistently report that white physicians by Black patients feel like they're less participatory decision-making styles, and it's independent of the length of the relationship and the patient educational background. I don't know how things are structured here at Stanford, but anywhere I've ever worked, it's been an issue where you see that there's differential care according to your insurance status. And so this is going to be a driver of disparities in outcomes. If you have government insurance and you're going to a clinic where you only see residents and they're poorly supervised, but you have commercial insurance and you go to have your private physician, you have this, warm relationship that you build up over the course of your pregnancy, you're going to see different health outcomes. And at Columbia, where I was working before, I know the dean and the health system became aware of this. And when I was last there, they were doing an experiment in neurology. They picked one area to focus on as a pilot program to see, can we manage to have payer agnostic care where everyone gets to have the same level of treatment. And what's interesting is that we think this is normal. In our society, we think that if you have more money, it's okay for you to get better care than this person that has less money. In our algorithms, we see where race is included when it actually has no meaning. And the problem is that it has the impact of exacerbating disparities. So the vaginal birth, the VBAC calculator, used to include race and predicted a lower success. And Bill Grobman has actually revised his calculator without race and found that it was I'm accurate. But, you know, I just use this as one example of many algorithms that include race and also can exacerbate disparities and do not really add much benefit to our clinical treatment. Our research dollars are very different according to race and even gender, where you see like the NIH had to tell people that you need to include women in studies back in the 90s, and we still have not reached the same level. Sickle cell and cystic fibrosis are great comparators because they're genetically based diseases. Sickle cell was the basis of it was discovered long before cystic fibrosis. And the population in the US that's affected by sickle cell disease is 3 times that of cystic fibrosis. And yet the funding dollars are far less for what most people see as a Black disease. We see many of you, I'm sure, most of you, I'm sure, are aware of the bias in pulse oximeter technology. And AI is, you know, it's actually here. It's not on the horizon. And we see that the biased information that we feed AI has caused a problem. This is not healthcare related, but I found it really interesting. The story where Amazon tried to make it easier to hire people and have AI create a recruiting tool where they say like, who's going to succeed at Amazon? So let's recruit those people. And it turned out that they completely excluded women. And because Amazon was like, well, the AI tool said men do better at Amazon, so let's not try to recruit women. And it's interesting because they tried to refine it and they say, okay, you cannot exclude women, but then they excluded all women who went to women's colleges because that was another marker of lack of success. So I think we have to just be very, very careful about what's to come and our reliance on AI in the future. So can we do anything about this? How do we counter these stereotypes and bias? There's been a lot of work done. There's things like stereotype replacement, asking people to try and think about people who they have stereotypes about and think of the counter stereotypic imaging. And some of these also count towards bias in terms of these same strategies have been used. But I wanted to share this particular study, which was really interesting to me, where they looked at people with different cognitive abilities. And I think this is pretty hopeful to me in some regards. So people who are privileged tend to look at people who are not as privileged are not as successful as maybe less intelligent. They probably don't work as hard. And this sort of legitimizes your success and your standing in society. And people who with higher cognitive abilities in this study were found to be easier to pick up on stereotypes because you're smarter, you're faster, you pick up on pattern recognition. So you actually tend to form stereotypes more easily. But what was interesting, and I won't go a lot into the details, they were trying to look at different types of faces and teach people what the stereotype about that look was in the study. And then they were able to actually switch when confronted with new information that challenged their pre-existing associations. So this is one study, but I just find it interesting that maybe we can do better if we actually intentionally try to reverse our stereotypes. The bias reduction strategies that you see in the literature are mostly around raising awareness, you know, grand rounds talks like this. Perspective taking is another way where you try to put yourself in the shoes of the person. If you are a tall, white, cisgender, cishet male, you walk into a room and you're standing, towering over a woman of color, a Black woman, maybe low socioeconomic status, who's poorly, you know, low educational attainment. Think about that power differential and imagine what it must be like to be in that person's shoes. And that, I think, is very helpful in sort of reducing our bias. Best practices are that this kind of training needs to be longitudinal. It can't just be a one-off. And it's important to provide people with skills and strategies. And I'll try to provide a few at the end. And it's better to be incorporated in your regular training curriculum. So where I've worked in the last few years, I've tried to make sure that this kind of training is part of the anesthesia resident core curriculum. It's not something that you have to go on a voluntary basis. And it also has to be accompanied by other systematic changes. So as I said, like if you want to affect health disparities, you can't just talk about it. You actually have to make a change in maybe how we care for our patients at a system level. These are some of the break the bias types of studies that have been done. One of my favorites, it's the top one, this contact hypothesis. If you are in contact with people, you're less likely to stereotype them. And this was from the 70s, the top one on, if you look at the upper right, it's fascinating. They took already people who are prejudiced white men who had already been identified. They put them in a real work situation in a railroad workers, and they paired them with Black Confederates. And this went on over months. And then they also had an observer who was a Confederate. It blows my mind that people actually did this. But then after the period of working together with the prejudiced white person, the Black Confederates, at the end of the study period, they did not know they were in a study. They rated the Black coworkers as more likable and intelligent, and just having that experience of working with people who were different from them, who they previously held prejudiced views against, that made a change. And again, another plug for DEI. We just have to have, not be in our bubbles with a single kind of in-group. So the implicit association test, I strongly recommend taking it if you have not. It can be found at implicit.harvard.edu. And it's been criticized as not being able to predict behavior. And but I think it's pretty, over the couple decades, it's been pretty well validated overall in terms of consistency. It's a simultaneous classification test. Has anybody here done the IAT? Okay. You don't have to reveal your answers. I know that I was very upset about mine, and I'll share. It said that I have a slight preference for white people, and I was devastated because I honestly believed that I would come out as completely like no bias at all. And it just shows what I have absorbed living in the world. And so I made everybody I know take the test, even my husband, and he came up as having a moderate preference for white people. And I was so happy because I was like, you're more racist than me. And this is awesome. I felt so much better. So in terms of the creating programs, whoever here is in leadership in DEI, you want to think about what your needs are, and make sure that any training sort of adheres to standardized educational curriculum development. So you want to figure out who your learners are, make sure the facilitators are well trained, and make sure, as I said, it's more of a longitudinal program. And you want to, of course, evaluate it and keep going this sort of process model for the educational curriculum. This is one project that we did at Columbia that I was very proud of. We got a grant from the provost to hold this. And this was during COVID, so we weren't able to gather in person, but we used this technique of forum theater. I don't know if anyone's heard about the theater of the oppressed. And this was a really nice way to get people involved and engaged and practicing the skills. So we had a couple different vignettes. Again, this is all online. The woman in top left was the perpetrator, because these are the roles that people play in these theater. The man in the upper right was her husband. The woman in the bottom left was a PACU nurse, and bottom right is a Black physician who was the target. And in the vignette, we had the woman had just gotten a upper limb surgery or knee surgery, and she was hurrying, trying to get home. She's like, honey, we have to, get the traffic, beat the traffic. And the husband's like, they're like, don't forget your charger. And we spotlit them on the screen. And the PACU nurse was saying, we need just to sign up from anesthesia. And our target walks in and they're like, good, transport's here. We're ready to go. Can you take me down to get my car? And he's like, I'm Dr. Brown, and I'm just here. I need to sign out and give you some instructions before you go home. And it sort of played out a little bit, and then we stopped and went into breakout rooms with different people. And then in a real person, in-person theater of the oppressed, actually, people will come down and they'll take over roles, and you sort of try and come to a consensus about what would be the best response. So in our setting, we went to breakout rooms, we came back, and the actors hadn't spoken to each other. So it was a really interesting experiment where then they came back and people had put the words in the nurse, like, when you see one of your colleagues being targeted like this, what would be your response? And so it's interesting way to get people engaged and involved in this process and learning skills. There are a lot of criticisms for DEI training and bias training and so on. One thing is apathy. I feel like so much of what has happened in this country in terms of race relations is just normalized. Like I said, we think it's normal for the Black and Hispanic and low English proficiency patients to go get lesser care than the wealthy white patients. And then there's the issue of cognitive dissonance, where people still can't they're grappling with the fact that they hold these egalitarian beliefs, but they're being told that, you hold bias, you are a little bit racist. And then, of course, if it's not reinforced, you get training effect decay. And if it's poorly done, it can actually backfire. People can be pretty upset and annoyed. I've heard that, like, there's some people who will be told that they're biased, and so their response is not to try to break the bias, but it's more to like, well, I'm not going in that room. The response is then avoidance. And, I freely admit even though I've told you about all these different types of studies, there's actually not a big, not a weighty amount of evidence to support how effective the training is. So I acknowledge that as well, because just because I've raised awareness in a talk doesn't mean that it's necessarily going to change my behavior in the real world. And how do you study that? How do you study what people are going to do at a later time? Most of the studies, the outcome measure is, do I feel more aware, and do I intend to change my behavior, which is not necessarily that solid or robust. We don't know what the right outcome measure is. There's no standardized assessment. If I do an intervention at Penn and you do one at Stanford, I don't know how we're going to compare it, because there's no standard way for us to compare the effectiveness of these. So as I said, it's very difficult to study behavior. Well, the last part of the talk focuses on the issue of discrimination, which is our behavior, this prejudicial conduct towards an individual or cohort. And, I won't go over the whole history of America, but just share one documentary that really shook me up. I don't know if any of you have seen this. It's the lynching postcards, because I had no idea of this event. As I told you, I'm an immigrant. This was not part of my education. And I learned that after, even after slavery ended, emancipation, over the next 100 years, 4,000 African Americans were lynched over time by mobs. And this concept of lynching postcards, this was a thing. You would go to see a lynching and it would be a big spectacle, and people would share postcards around the country, which is just absolutely horrific. And I know we don't have any racism to that extent anymore, but you're still seeing a lot of racial resentment in the country. And I'm going to digress just a little bit to tell you why I think this is an issue. And some of this is from reading some of the work of Heather McGhee. And the idea is that problem, I think, is that we have a zero-sum ideology. If we are giving minority individuals a chance to succeed and thrive, it's going to take away from me. And it's always been an advantage to be white in this country. So the Irish came over, they weren't considered white, and that was an aspiration to become white in the country. I don't know if you guys realize that when Italians came to the US, they were not considered white. There was a slur, which I'll say, but it's ugly. They were called guineas because they think they were compared to Black folks. So I think what the struggle is thinking about privilege versus oppression. And in the DEI world, we were all horrified by this story last year where the DEI officer, the chief officer, diversity officer at Johns Hopkins, had to step down. And she stepped down because of her explaining what privilege is. And I'm going to be brave and say what privilege is, because this is exactly what privilege is about. The idea that through no, fault or through no action on your own, if you are a tall, white, heterosexual man, you're going to have greater privileges than a small stature, disabled, minoritized person. And so we need to come to terms with the fact that these attributes which are not earned can provide us privileges in society. And this is just a wheel just showing the opposite. If you are a Christian, you probably have more privilege in society than if you're not Christian. If you're LGBTQ versus or trans versus cisgender and heterosexual, disability, immigrant status, English proficiency, all of these things are examples of privilege versus oppression. And it's important to also recall that there's intersectionality, trans, feminine, Black people tend to have more episodes of violence against them than their white counterparts. So that is the concept that different intersecting identities can change your level of privilege versus oppression in society. And then there's just a concept also of positionality. If you are a Black surgeon and you are commanding the room, but you go to a store down the street and you might be followed and seen as a threat just because you're Black. So different positionality can impact your experiences. And I urge you to read the book, The Sum of Us by Heather McGhee, because this is one example of the zero-sum ideology she talks about. I don't know if you knew, but I didn't know. The public pools were a big thing in America. This is one of the biggest pools in the country, in St. Louis, Missouri. This public pool had a capacity of 12,000. And in the 1940s, when the director of public welfare decided to desegregate the pool because only white people got to use the pool, it ended up in bloody race riots. And it ended up that the pool had to be completely closed a few years later, filled in with cement. So nobody gets a pool. And this is a zero-sum ideology that we can't let you get this advantage. And so this benefit, if it's not only for whites, nobody gets it. And this is another image that I found that was very disturbing. The idea that there were Black people protesting at this hotel trying to use the pool, and the owner actually dumped acid while they were swimming because, how dare you? And, some of I know that affirmative action, where we are today, but it was interesting to look up some of the cases. Alan Backey had been rejected twice from UC Davis. He had been actually rejected from 12 medical schools, but he sued the one that held set aside seats for minority patients. And this made it to the Supreme Court. This man had been rejected from 12 medical schools. Abigail Fisher, similarly, had trouble getting into UT Austin. And she focused on the fact that 5 students who were Black and Hispanic had lower scores than she did, even though 42 white folks also had scores lower than she did. But the focus was on the fact that how did these Black people get in ahead of me? And so I want to talk about where we are today. We're not seeing as much overt discrimination, but I'll close out just talking about this idea of microaggressions. Chester Pierce coined the term in the 1970s, and he was really influential. I didn't realize that he actually was hired by Sesame Street, to increase the, more positive images of Black people. And I won't spend time. Anyway, I think that is really depressing, the fact that we had to, in the 70s, be telling kids that you are somebody. But anyway, this is where we're coming from, folks. Daryl Wing Sue at Columbia University took the concept further.
And the everyday rights, dignities, put downs, and validations that people experience, that people of color experience in their day-to-day interactions with well-intentioned, well-meaning people who are unaware that they have delivered a put down or validation.
So since Daryl, brought forward this idea of microaggressions, there have been hundreds of studies, lots of trainings. And, in 2025, I think you're all aware that there has been a major backlash against diversity, equity, and inclusion programs. And there's this cancel culture and gaslighting of people. And I think what was really informative was to hear Daryl Sue. He believes that we need to go through this painful period to get to the other side. I've personally experienced some of these microaggressions as a Black woman working in healthcare in the US. I've been asked to change a toilet paper. I've gone with a colleague to remove an epidural, and they said, "Hey, transport, glad you're here." And so these things seem very small, but when you are a person of color, they just keep happening over and over and over. And it's like getting a paper cut. It's a small thing, but it stings and it's really irritating, and it weighs on you over time. And, I was telling you that my husband's Jewish, and for me, going to grocery stores are just triggering because no one ever thinks we're together. So we're at the checkout counter and I get, ma'am, can you please allow this gentleman to finish his purchase? Can you please step back and give him some room? Like, together, it's just over and over and over. It's to the point where if I go to the grocery store with him, I actually just slip out to the front and I'll just wait for him because I just don't want to experience that. It's over and over and over. In terms of the taxonomy of microaggressions, Daryl Wing Sue has come up with this categorization. One of the worst is the microassaults. That's the ones where they really want to insult you. And I don't even know if you can call it micro in any way. I got this from Twitter, which is just, it seems topical because of the LA fires, and they're saying that blame DEI because we're having fires. Everything's now blamed on DEI. But it's also things like people saying like, "Oh, I'm so surprised that you speak good English," because if you're a foreigner, they think that you're probably not quite as intelligent or competent. I really like this one. This was from a study of microaggressions for college students. This woman says, "I was coming down the stairs and this really tall guy flinched." And she's like, "I'm 5'3", I'm not going to injure you." But this idea that Black people are more threatening. Asian Americans encounter this a lot, where it's, this idea that you're a perpetual foreigner. People saying, "Where are you from?" And you'll say, "Well, I'm from Seattle," or "I'm from San Francisco." But no, where are you really from? You're not really American, are you? And I won't go into all of this, but there's the exoticization. "Can I touch your hair?" For Black women, that's a very common one. I've gotten the same racial categorization and sameness. I don't know for the Black people in the room, or I think this also happens a lot to Asian people. If you have another Black resident or fellow, or everyone seems to think you're the same person, that's another issue that we all face. So why do we do this? I think it's really interesting. Jonathan Cantor at University of Washington has found that we tend to just get hooked on these category activation. We see someone, you're different, and you just hooked by their features. And it seems to be people who are more likely to endorse colorblind attitudes, are more likely to end up actually committing these microaggressions. And if you're generally more conservative, it seems that you are have a higher likelihood of also committing these aggressions. And as I said, the impact is not micro. They've shown that there are higher levels of depression, anxiety, PTSD, and so on, higher levels of burnout in people who experience these on a regular basis. And in case you're interested, it's not mediated by negative affectivity, or otherwise known as neuroticism. So it's not Black people's fault. So number one, if people tell you that they've experienced a microaggression, believe them. Please don't gaslight them. I was asked to take out toilet paper in front of a bunch of nurses, and I said, "Oh my God, did you just see that?" And they're like, "Oh, it's nothing. Just because we're all wearing the same scrubs, they can't see us different." I'm like, why did they come to me out of all the white people I'm standing next to? So just believe them. If you see it, make the invisible visible. If you see a friend doing this, you figure out what your word is, or your code word. But Gerald Wing Sue suggests saying "ouch" like you stub your toe, and being like, "Oh, that was kind of harsh," Sometimes you need to educate people, just saying like, I think it's a more inclusive term to say this rather than that. A lot of people who commit microaggressions think the person's being too sensitive. I didn't mean it. Just get over it. But it's not what your intention is not the most important part. It's understanding the impact that you're having. And Daryl Wing Sue, addresses this issue where people say like, "Oh, I have to walk on eggshells around people of color." And he said, you'd rather be oblivious? Is that because that's the alternative? Disarming the microaggression is important. If you start to hear someone tell a joke that sounds like it's about to be racist, you might say, like, let's not go there. How about we change the subject? Taking the person aside, redirecting the person who's committing the microaggression, confronting them. What did you mean by that? And making sure it's clear that it's not okay. Emphasize how it made you feel, and learn how to apologize, because I commit microaggressions all the time and I have to make amends. One of the things that stands out to me is I walked into a Hispanic patient. I saw the name. I walked in and I went guns blazing. I was really busy speaking Spanish, introducing myself in Spanish, and the woman went, "What are you doing?" I speak English. And I was like, "Oh my gosh, can we start over? I'm so sorry, I just made that assumption," and you move on. Uplifting targets. This was one of, well, it's happened to me more than once, but sometimes, we get these requests. I want an attending to do the epidural. And I've had patients upset saying, I told you I want the attending, I want a doctor. And this is not the patient, but this is what you're thinking, like, do I really have to deal with this again? And what's helpful in some of these situations is a nurse saying like, "Oh my gosh, this is the attending. You're so lucky. She's the best." And it's really nice to have someone just sort of stand up for you as an upstander and show allyship versus me having to defend myself to the patient. And it's not necessarily the savior complex. It's just more like standing up for other people. And if this is happening to you as a resident, because of the hierarchy in medicine, you may need to seek support. We need to develop more skills-based, validated, effective curricula, and we need more objective, validated outcome metrics. And as I close out, I just want to mention that I don't think interpersonal bias is the only contributing factor to health inequities, but it's one of the few things that we actually can have some control over, how we behave and how we treat people. There's obviously a lot of structural factors that impact what happens. And I also want to mention that even though we talked a lot about race today, this impacts all marginalized groups, whether they're refugees or LGBTQ. And right now it feels like we're in a very dark place. I think a lot of DEI programs, a lot of backlash. And I want to just encourage you, but I think that we just need to keep pushing, and we'll see the light at the end of the tunnel. Thank you.
So I've got the mic. If anyone has any questions, I can walk around and pass it to you. I also want to give Sheila some time to make a comment later, given the fact that this is a lecture and an honor. Is there anyone here who has a question at all?
Hi, Alison. Thanks so much for a really interesting talk. I just had a question about the classification of race and ethnicity, and maybe as time goes on, this may change. I wanted to know your thoughts about clumping all white people into one group, all black people into one group, without taking into account all the other multiple factors that exist into making someone who they are.
I agree that we need more refined ways to, first of all, mention this as social categorization. It's not biological. And I know that in the UK, it's very different. You look, when you talk about ethnicity, you're not just saying Hispanic versus you're Caribbean or you know, and I think there's so many nuances and differences socially, depending on different geographic ancestry and backgrounds. So I agree with you that we need better. In New York, I just saw that the governor announced that they're now going to, for state stuff, instead of just saying having Middle Eastern and North African people classified as white, they're going to be able to now identify that they are a separate group. And there's so many people lumped together with white, which is really problematic when you have an Ashkenazi Jew versus an Arab from Lebanon or, you know, someone from Norway, and they're all white and they're going to have very different biological characteristics.
There's a question online. Can you comment on how DEI programs will have to adapt, not only because of the changing political climate, but also the societal backlash, as you mentioned, against DEI programs in the last few years?
I think we need to just hold steady for now. That's my personal opinion. I've also heard colleagues say, like, we need to just go underground right now, you know, pull everything from the website. Let's just pretend it doesn't exist and then we'll work secretively. And I personally think that we need to have a bit more courage. And I think that, you know, we've seen this before. And I always say that groups with privilege have never given up that privilege easily. You know, it's like women can vote. Really? Do they have to? You know, women had to protest, and, you know, there's a civil rights movement. You've always had to go through a period of struggle for equality.
Another related question online saying, well, firstly, thanks for an excellent talk. Do you have examples of successful DEI programs on a macro political and or corporate level? So are there any success stories you can share with us? I
mean, that's tough to answer briefly. I feel very proud of what we did when I was there at Columbia. I've only been at Penn for a year, so we're just going through our first cycle. But I remember having a DEI evening, and one of the questions was, can you please explain you have exactly 0 residents of color in your CA1 class? And I think that what we have now is a success, where, you know, something like 30% of the class is, you know, they're Black and people of color. 40% of one of our classes is LGBTQ. And so by just being intentional about it, focusing on it, not just assuming that things are going to fall into place, being aware of what we think is a fit here. And, you know, one of the schools in New York, the City University of New York, has a very special program where they take underprivileged kids and they take them from high school through to med school. And in that time when I was there, we took our very first person from that program. And I mean, when I found out, I was bawling. I was just so happy that we're actually doing something and pushing forward.
Are there any questions from any members of the audience? All right, so I'm going to close up. It's actually a little over time. So thank you very much, Allison, for a superb talk, and look forward to entertaining you for the next few hours before you head off.
Thank you. Thanks.